To assess cranial nerves 1 through 6 in adults, you ask questions and record answers. But in a pre-verbal child, subjective reporting is impossible. Without the ability to rely on the patient's description of their symptoms, the examination has to discard questioning entirely. The clinician must instead deduce the state of the nervous system through objective, observable data. This deductive process relies on 3 specific pillars: age-gated physiological thresholds, binary reflex loops, and mechanical tension of unopposed muscles. Physical signs like a dilated pupil, an outwardly deviating eye, or a jaw shifting off-center are precise anatomical roadmaps pointing directly to specific nerve deficits. By treating the central nervous system as an interconnected mechanical and electrical circuit, clinicians bypass developmental barriers to pinpoint lesions by mapping the failure points in the circuit. Sensory assessments face strict developmental gating. Accurately testing the first cranial nerve, the olfactory nerve, and mapping the visual fields of the second cranial nerve cannot be done reliably in children under 3 to 5 years old. For patients over 5, the olfactory testing protocol requires specific parameters. You must use non-irritating substances, like chocolate, because harsh smells will bypass the olfactory nerve entirely and accidentally trigger the pain receptors of the trigeminal nerve. Based on the patient's response, specific deficits are categorized. A total loss is anosmia, a decrease is hyposmia, an increase is hyperosmia, and a distorted sense of smell is parosmia. This formula illustrates how we calculate visual acuity. V equals D divided by capital D. The lowercase d is the test distance, and the capital D represents the smallest line of letters a normal eye can read at that specific distance. Normal visual acuity follows a predictable trajectory. At birth, a child's baseline is roughly 6/45. Over time, the visual system refines its focus, reaching standard 6/6 vision by age 6. If a child cannot read the largest line on a standard Snellen chart from 6 meters away, the testing algorithm drops to its first fallback step. The distance between the patient and the chart is cut exactly in half, down to 3 meters. If failure continues, the algorithm collapses sequentially. The clinician moves to 1 meter to see if the child can count fingers. If not, they test for gross hand movements, and finally, they check for bare light perception. The patient's developmental age acts as a strict parameter, dictating how far a clinician must descend the sensory algorithm to find a reliable baseline. Moving past sensory testing brings us to objective physiological responses. The pupillary light reflex is a hardwired neural circuit requiring 0 patient cooperation to evaluate. This circuit diagram shows the wiring of the reflex. The optic nerve, or cranial nerve 2, acts as the sensory afferent limb. It captures the incoming light signal and transmits it inward. The brainstem processes that signal and completes the loop. The oculomotor nerve, cranial nerve 3, acts as the efferent limb, sending a bilateral motor command back out to constrict both pupils. We can test this circuitry using hypothetical logic gates. Consider an isolated lesion on the left optic nerve. Shining a light into the left eye hits a dead wire, producing 0 pupillary response. But shining a light into the right eye travels cleanly up the intact right afferent nerve, producing normal bilateral constriction. The system proves the left input is broken. Now let's move the damage. If the left optic nerve is intact, but the left oculomotor nerve is severed, the logic changes entirely. Because the left motor output is broken, the left pupil cannot constrict under any circumstances. However, the right pupil will constrict whether the light is shined into the left eye or the right eye. By treating these reflex loops as strict binary inputs and outputs, a simple flashlight test provides mathematical proof of which exact nerve is damaged and on which side of the brainstem the lesion sits. A parallel visual loop exists called the accommodation reflex. Activating it triggers 3 simultaneous actions. The eyes converge, the ciliary muscles contract to change the lens shape, and the pupils constrict. This sets up a specific clinical paradox. A patient can present with an entirely absent pupillary light reflex, yet their accommodation reflex works perfectly. This precise diagnostic anomaly is known as light-near dissociation. This map of the midbrain reveals the neuroanatomical cause. The center controlling the accommodation reflex sits physically deeper, in a more ventral position, than the pretectal nucleus, which controls the light reflex near the dorsal surface. This physical spatial gap is targeted by specific pathologies. The resulting damage causes the Argyll-Robertson pupil, famously seen in neurosyphilis, as well as deficits in dorsal midbrain syndrome and diabetes. Uncovering light-near dissociation proves that clinical anomalies are rarely physiological errors. They are exact blueprints of microscopic, localized lesions deep within the brainstem. We can apply this same objective logic outside the internal brainstem circuitry, evaluating the external biomechanics of the extraocular muscles. The foundational mechanical rule is simple. Paralyzed muscles don't just stop working. They yield to the constant, unopposed tension of healthy antagonist muscles. This 3D model isolates the extraocular innervation formula. The lateral rectus muscle is powered by cranial nerve 6, pulling outward. The superior oblique is powered by cranial nerve 4, and the remaining cluster of ocular muscles is driven by cranial nerve 3. Watch what happens during a cranial nerve 6 or abducens palsy. The outward lateral rectus vector is lost, meaning the eyeball is relentlessly pulled inward by the unopposed medial tension. If we restore nerve 6 and simulate a cranial nerve 4 trochlear palsy, the superior oblique vector fails. Unopposed tension forces the eye to mechanically deviate upward and outward. Finally, a cranial nerve 3 oculomotor palsy causes a massive loss of multiple muscular vectors. Only the lateral rectus and superior oblique remain active, dragging the eye severely down and out. Because cranial nerve 3 also supplies the levator palpebrae superioris muscle, this specific mechanical deviation is strictly accompanied by a drooping eyelid, unilateral ptosis, and a dilated pupil. In a neurological context, pediatric strabismus functions as a mathematical vector pointing away from a compromised cranial nerve. This exact principle of unopposed mechanical tension also governs the lower face, specifically the motor component of the fifth cranial nerve, the trigeminal nerve. While the trigeminal nerve's sensory integrity is tested through facial touch localization, its motor strength is evaluated through the balance of the masseter, temporalis, and pterygoid muscles. Clinicians test this by asking the child to open their mouth and protrude the jaw, assessing bilateral pterygoid strength against resistance. Applying vector logic to a trigeminal palsy yields a distinct mechanical result. If one pterygoid muscle is paralyzed, opening the mouth causes the jaw to deviate toward the paralyzed side, physically pushed out of alignment by the healthy contralateral muscle. This brings us to the final overarching logic gate, one that tests two entirely separate cranial nerves simultaneously, the corneal reflex. Eliciting this reflex traces a crossover pathway. The ophthalmic division of the trigeminal nerve registers the physical touch as a sensory afferent signal. It instantly relays that data to the facial nerve, cranial nerve 7, which executes a bilateral motor blink. Eliciting a single successful reflex proves the functional integrity of a sensory nerve, a motor nerve, and the complex brainstem architecture bridging them together. Clinicians achieve diagnostic precision by reading the body's hardwired circuitry rather than attempting to force adult-level cooperation from a pediatric patient. Physical signs like a unilaterally dilated pupil, an inward-turned eye, or a deviated jaw are precise data outputs from a compromised neuromechanical system. By evaluating these reflex logic gates and muscular tension vectors, clinicians reverse engineer the nervous system to locate the physical origin of a nerve. When a patient attempts a forceful smile and the entire right side of their face remains completely slack, it presents an immediate clinical tension. This is unilateral facial paralysis, and it signals a break somewhere along the 7th cranial nerve. Assessing this damage requires an investigation into the anatomy of the brainstem and skull. The 7th cranial nerve is an anatomical marvel with varied functional branches. Because of this complexity, any damage to it leaves a specific, readable trail of physical symptoms to follow. Interpreting these findings requires mapping the core functions of the nerve, establishing the exact differences between central and peripheral lesions, and then using the physical exam to pinpoint the damage. Mastering the mechanics of this specific nerve places various patient symptoms onto a solvable, precise anatomical coordinate. This is a foundational wiring diagram of the brainstem and skull. To understand how the 7th cranial nerve works, we wire it from scratch. It operates strictly on a rule of 3 mixed function framework. The first function is motor. These fibers drive literally every muscle of facial expression. There is one anatomical exception. The nerve entirely bypasses the levator palpebrae superioris, the muscle responsible for lifting your upper eyelid. The second function is sensory. A specific branch called the chorda tympani carries the sensation of taste away from the anterior two-thirds of the tongue and routes it back to the brain. The third function is secretomotor. These pathways drive lacrimation and salivation, connecting directly to the tear and salivary glands. This mixed bag of motor, sensory, and secretomotor wiring is what allows a clinician to reverse engineer exactly where the circuit is broken. Determining if the nerve damage is central, meaning up in the brain, or peripheral, out in the nerve itself, dictates the entire diagnostic approach. In neurology, this is the upper motor neuron versus lower motor neuron dichotomy. We start with the upper face. The upper half of the facial nucleus receives bilateral input. It gets descending corticobulbar tracts, essentially backup wiring, from both the left and right sides of the cerebral cortex. The lower face lacks that secondary backup signal. The lower half of the facial nucleus receives strict contralateral input, meaning it only gets signals from the opposite side of the brain. If we simulate an upper motor neuron lesion, a central injury in the cortex, the lower nucleus loses power. The opposite lower half of the face is paralyzed, but the upper nucleus stays perfectly intact because the healthy hemisphere continues supplying its backup signal. The patient can still wrinkle their forehead. A lower motor neuron lesion happens out in the peripheral nerve, after the signals have already left the nucleus. A break here wipes out all descending signals instantly, paralyzing the entire half of the face. A lower motor neuron lesion also brings 3 specific physical signs: muscle atrophy, an involuntary upward rolling of the eye known as Bell's phenomenon, and a completely absent corneal reflex. The presence or absence of forehead wrinkling creates the visual contrast that dictates an entirely different diagnosis and treatment plan. To test the facial motor functions, we start with the absolute basics. You check symmetry at rest, ask the patient to wrinkle their forehead, and have them show their teeth. Then, the cheek puff test. The patient blows their cheeks out. If there is lip muscle paralysis, air will simply leak straight out of the affected side due to weakness. Attempting to forcefully shut a paralyzed eye triggers Bell's phenomenon. The eyelid fails to close, and the eyeball involuntarily rolls upward, exposing the white sclera. Shifting to the sensory circuit, we test the chorda tympani branch through taste. The testing order is strict: sweet, salt, sour, and bitter last. The patient extends their tongue, the taste is applied, and they have 10 seconds to identify it. Failing this specific sensory test proves the nerve damage is located somewhere structurally prior to the point where the chorda tympani branches off. We evaluate the secretomotor function with Schirmer's test. Thin strips of filter paper are placed inside the lower eyelids to accurately quantify and compare tear production symmetry across both eyes. The corneal reflex functions as a complete sensory motor loop. The sensory signal travels up to the brainstem via the trigeminal nerve, but the physical blink response travels right back down through the facial nerve. By systematically testing these reflexes, sensory outputs, and motor functions, clinicians document isolated failures to rule out entire branches of the neural network long before an MRI is ever ordered. We can track the central pathways step by step from the cortex to the periphery. By looking for collateral damage to neighboring neurological structures, we can pinpoint the exact location of the lesion. If the lesion is high up in the cortex or the internal capsule, you will see a dense hemiplegia, paralysis of one side of the body, alongside the facial symptoms. Moving down to the facial nucleus in the pons, the 7th nerve physically wraps around the 6th cranial nerve, the abducens. A lesion located here typically knocks out both nerves at once. Tracking further out to the cerebellopontine angle, the 7th nerve travels right alongside the 8th cranial nerve. Damage at this specific checkpoint brings hearing loss and ataxia into the clinical picture. Consider a specific clinical presentation along the pathway. A patient presents with normal tear production, but they exhibit hyperacusis, extreme sound sensitivity, along with a loss of taste and a facial palsy. Because tears are normal, but taste and sound regulation are compromised, the damage is trapped in the exact anatomical space between the geniculate ganglion and the second genu. Finally, an isolated facial palsy with absolutely no other sensory or secretomotor symptoms indicates terminal damage way out at the end of the line, inside the parotid gland. Checking tears, hearing, and taste operates exactly like a fault line detector. It allows us to deduce the exact location of a snapped power line without ever looking inside the wall. The physical exam of the seventh cranial nerve is a strictly logical diagnostic algorithm. By checking facial symmetry, isolating reflexive loops, and mapping sensory outputs, a clinician converts a series of physical findings directly into exact anatomical coordinates. It is a process of reverse engineering the anatomy until you reach a fully intact, fully functional facial nerve circuit firing in perfect symmetry. If one single nerve provides this level of precise topological mapping, consider the depth of diagnostic information waiting to be found in the physical exams of the remaining. To accurately map the lower brainstem, we have to evaluate the pathways of cranial nerves 8 through 12. These lower cranial nerves govern complex, vital functions: hearing, equilibrium, swallowing, and airway protection. Testing them necessitates an analysis of physiological responses to specific physical stressors. The physical exam here operates as a mechanical differential diagnosis. We apply targeted stressors to the nervous system. By observing specific asymmetries in the patient's physiological response, we map the exact location and type of the neurological lesion. The vestibulocochlear nerve, cranial nerve 8, splits into two divisions. We begin with the cochlear or auditory pathway. Bedside hearing assessment starts with quantitative distance and decibel thresholds. A whispered sound at a distance of 15 centimeters roughly equates to a 35 decibel stimulus, while conventional sounds, like a hand clap or a bell, test the 50 to 60 decibel range. If a hearing deficit is detected, we isolate its mechanical cause using a 512 Hz tuning fork. The Rini test does this by comparing how sound travels through the air to how it travels through the bone of the mastoid process. This split-screen vector diagram compares those two pathways. Normally, air conduction is superior to bone conduction. This is labeled Rini positive, and it remains true even in a patient with sensory neural hearing loss. But if there is a physical obstruction, conductive hearing loss, bone conduction becomes the superior pathway, resulting in a Rini negative test. We further define the deficit using the Weber test. We place the vibrating tuning fork directly on the midline of the skull, such as the vertex, so the sound travels symmetrically down both sides. Continuing with this model, we analyze where the sound lateralizes. If the sound lateralizes to the affected, poorly hearing ear, the patient has conductive hearing loss because ambient air noise is blocked and the bone-conducted sound dominates. If the sound shifts toward the normal ear, it points to a sensory neural deficit on the silent side. Comparing these tuning fork asymmetries instantly differentiates a mechanical obstruction from a neurological source of hearing loss. The second division of cranial nerve 8 is the vestibular pathway. Dysfunction here presents clinically as equilibrium issues, vertigo, and nystagmus. When nystagmus originates from a vestibular nerve deficit, the eye movement follows a strict directionality. The fast component of the reflex is directed away from the affected nerve. To test this in a patient with vertigo, we use the Fukuda stepping test, asking them to march in place with their eyes closed for 50 steps. A rotation of more than 45 degrees toward the affected side indicates a specific vestibular nerve dysfunction vector. The Romberg test narrows the differential. If a patient maintains balance with their eyes open but falls when they close them, the defect lies in the posterior columns of the spinal cord. If they lose balance even with their eyes open, the dysfunction is isolated to the vestibular system on the side of the fall. The caloric test allows us to directly stimulate the vestibular system using temperature. This test requires an intact, unobstructed tympanic membrane and the patient's head elevated to exactly 30 degrees. This diagram shows the physiological reflexes triggered by irrigation. Cold water at 3 degrees Celsius drives the fast-phase nystagmus vector to the opposite side, while warm water at 44 degrees drives it to the same side. These involuntary eye movements verify that the neural circuit between the inner ear and the brainstem is intact. By inducing these reflexes, the clinician can confirm brainstem integrity or isolate a peripheral equilibrium defect. Cranial nerves 9 and 10, the glossopharyngeal and vagus nerves, are tested simultaneously. Because they share anatomical pathways and execute redundant functions, we evaluate them as a shared bulbar complex. Sensory information travels up the afferent pathway of the ninth nerve, and the efferent motor response returns via both the ninth and 10th nerves. Before testing their shared reflexes, we check the primary isolated target of the ninth nerve, taste sensation on the posterior one-third of the tongue. We then test the shared gag reflex arc. Triggering the sensory afferents in the pharynx results in a three-part mechanical efferent response. The soft palate and uvula elevate, the oropharyngeal wall constricts, and the glottis closes. The resulting reflex identifies supranuclear pathology. Because of bilateral corticobulbar innervation, a unilateral supranuclear lesion produces no observable deficit. However, a bilateral supranuclear lesion results in a hyperactive gag reflex, as seen in pseudobulbar palsy. A unilateral infranuclear or nuclear lesion produces a distinct asymmetry, an ipsilateral drooping of the soft palate. This diagram of a phonation test illustrates the specific diagnostic vector of that weakness. When the patient says "ah," the paralyzed side remains flat, and the contracting muscles on the healthy side pull the uvula off-center, pointing directly toward the normal side. A bilateral palsy of the 10th cranial nerve presents with profound dysphagia, nasal regurgitation due to velopharyngeal insufficiency, and critical autonomic dysfunctions, including tachycardia and loss of the oculocardiac reflex. Assessing this shared bulbar complex evaluates the critical intersection of neurological airway protection and swallowing mechanics. The final two lower cranial nerves, the spinal accessory and the hypoglossal, function as pure motor execution pathways. We assess the spinal portion of cranial nerve 11 by testing the sternocleidomastoid and trapezius muscles against manual resistance. This model of the neck and shoulders demonstrates the counterintuitive mechanical vector of the sternocleidomastoid. Contracting the muscle on the left side pushes the head into a rotation toward the right. For the trapezius, weakness is identified visually by observing a drooping of the shoulder and an asymmetrical contour of the scapula when the patient shrugs against resistance. Finally, we assess the hypoglossal nerve, cranial nerve 12. Resting atrophy and fasciculations of the tongue directly indicate nuclear or infranuclear lesions. As this top-down vector diagram shows, the logic of tongue protrusion relies on two parallel genioglossus muscles pushing forward. If one muscle is paralyzed, its vector fails. The healthy muscle continues to push, driving the tip of the tongue in an arc toward the paralyzed side. Understanding these muscular push and pull vectors allows for the instant bedside identification of unilateral motor nerve deficits without advanced imaging. Returning to our complete 3D model, we can review the comprehensive diagnostic utility of examining cranial nerves 8 through 12 as a single interconnected region. Effective bedside diagnosis is built on identifying these functional asymmetries. Synthesizing the underlying vectors, air versus bone conduction, reflex arcs, and muscular push and pull mechanics, precisely localizes lower brainstem and peripheral pathology. Mastering the mechanics of these lower cranial nerves completes the bulbar anatomical picture, providing the necessary clinical foundation for broader, full-body motor systems.